This podcast was produced by OAR FM Dunedin with support from New Zealand On Air.
Welcome to the OI podcast, the Otago Institute podcast, in-depth conversations with experts from the worlds of arts, sciences and mataranga Māori. Brought to you by the Otago Institute, the Otago branch of the Royal Society for Arts and Sciences. Kia ora, I'm Dr. Barb.
And I'm Trudy, and today we have with us Pete Hodgson, who I would refer to as the Alistair Campbell New Zealand Labour politics, but then I might have to explain who Alistair Campbell is, and Pete might not like that. But for those out there, it's not too long a bow to draw, given that Pete's involvement with the Labour Party began as a campaign manager in 1977 and finished after holding various ministerial positions in the fifth Labour government, of which health was a major portfolio, which we're going to talk about a wee bit about today. As well as being the MP for Dunedin North for 21 or so years, he's certainly got a wealth of knowledge about our local community. And then he's also held positions on the Callaghan Board and the Otago Innovation Centre. And of course, what is topical for us is leadership of the Southern Partnership Group. But what listeners might not know is that Pete was also a vet, taught at Otago Girls High School, and has been a fruit and vegetable retailer. So welcome along, Pete.
Gosh. Thanks for having me.
That's quite an introduction.
It is. I think I've forgotten half of that. So thank you for having me, and let's talk.
Yeah. So I was surprised there. I've been a long time politics follower, not quite as long as Trudy. But she kicks me under the table when I say things like that. But I didn't realise that you were a vet or that you'd been a teacher or a fruit and vegetable.
Well, yes, I did my first degree in veterinary science, and I practised in New Zealand and Britain for about 10 years, and I wanted a change, so I rang up the Otago Girls High School and said I could teach physics. Oh. And then the students and I both learned a lot as we went along, and that actually turned out to be rather good because all of the things that I had difficulty in reminding myself about physics, I knew they would have difficulty. I ended up being quite a good teacher, thoroughly unqualified. And then the Ancient and Royal Anti-Scurvy League was a little business that used to buy a load of...
this is the fruit and vegetable retailer.
There was no scurvy in the entire period of our operation throughout Dunedin North, not one case. And
was there scurvy before that?
I just can't comment on that. I wasn't around.
Right.
But we had no scurvy, and we used to take a truckload or a truck and a half load of veggies down to the campus Mondays and Fridays. Start at 5 o'clock in the morning at the market, finish at 6 o'clock at night at the university, and go to the Captain Cook and drink the proceeds. That's roughly that business. Yeah.
What
a great business model! I like that.
Good business. And now the fifth Labour government, of course, that's the Helen Clark government,
that's right,
as we call it. Those of us who don't count. How did you go from fruit and veg into politics?
It was in my blood. I don't know how it arrived, but it was in my blood. And I worked as an organiser for the Labour Party for a while.
Did you mean, when you say in your blood, was it family connections?
No, I don't know how it got there. I mean, if I'm to give you a slightly serious answer, it would be to say I've never been able to understand or tolerate poverty. I just don't see the need for it. It seems a ridiculous idea, and that society should arrange itself so that we don't have very much of it. That would be good. And I, as I grew up and became more aware of what was going on around me, I became a greenie. So I was involved in the Clyde Dam and the Aramoana campaign and so on.
So sort of big scale environmental issues of the time.
That's right.
Yes, yeah.
That's right.
And so we're going to come back if we could, to the Southern Hospital, the Dunedin Public Hospital, and we thought we'd start off the discussion just maybe with some general health system questions, just to kind of set the scene for New Zealand health system. And the first one is there an integrated health needs plan for New Zealand? And if not, why not? And how do we factor into that local community needs?
You've used the word integrated health needs plan, so that's all loaded with certain adjectives. I don't quite know what you mean by them, but I can tell you that the health system is awash with strategies. We don't need any more strategies.
I guess what we're meaning is there an overall way that the health system in New Zealand works, where someone looks at what the health needs are across the country and plans for those in the near future, and says, okay, well, we've got an old hospital here, we've got too few hospitals in this area, we need more hospitals here, because obviously New Zealand's quite spread out and some places are quite concentrated areas of population like Auckland, and then parts of the country like the whole southern area are really spread out. So there's different health needs for different communities. And I guess that question is looking at, is there like some kind of like overall strategy for the coping with the health needs, in much the same way as you think about like there's a traffic plan. Like we know where we need to build new highways, if we have money to build a new highway, if we deem that important, where we would put the next highway or where we need to upgrade them. Do we have a similar thing for hospitals and health needs? So
this is a bit of a long-winded answer. You're going to have to stick with it.
Okay.
The first point is a point of agreement, and that is to say that we do not have the equivalent of Waka Kotahi's 10-year plan for horizontal infrastructure, land-based infrastructure, that gives contractors and publics and communities some idea of what's going to happen, and indeed some idea of what's not going to happen at their place in the next year or 10. We do not have that equivalent. The next thing to say is that it isn't that difficult to pull that one together. It's just not that difficult, and
so there's parts of that, or there's the information there that you could put it together if you had a political agreement to do such a thing.
There's no difficulty getting agreement to do such a thing. You don't need to.
What's the stumbling block? Why haven't they done it? Like, it seems to me the obvious thing to do to have
Still trying to help you with the answer to the question.
Sorry. Carry on.
So just so what's happening with the health system is that we've got a when Te Whare Ora formed up, now only 2 years ago, let's remember, they began anew looking at assets. So asset management plan, which is the old bits, which are the bits that we can get a whole lot more out of. And so
asset there, you're talking about hospitals and like the capital structure, but also doctors and nurses and how many.
No, not doctors and nurses. So when the word asset that in the use that I'm giving it is all capital works, but it might be a linear accelerator. It doesn't have to be a hospital,
right?
So Te Whare Ora are these days trying to get a better grip on that than existed in the DHB days, where, with the benefit of hindsight, you could say that asset management wasn't good. Why wasn't it good? Because people were saying that they needed more healthcare. Don't you tell me that we need to reduce service so that we can fix up the external of the building or stop the roof leaking. We've got pressing needs, ladies and gentlemen. We must address these unmet needs. And so in health, always, because there's no such thing as enough money in health, there's always a question of, do you give it to the person with tears in their eyes in front of you or their child, or do you spend it on boring stuff like fixing, the stairwell?
Right.
And asset management in hospitals uniquely, well, not uniquely, but especially tends to take a back seat. And a really good example of that is the ward block in Dunedin, opened in 1980, and a shambles. You know, it's its own story, but lets me just get away by saying it's a shambles, and it's a damn shame. It's actually a bit of an outrage that we could have a building that's now 44 years old and have as many problems as it has. It's dreadful.
And I suppose that's part about it's kind of an integrated health needs plan, because in health it's so difficult, or perhaps more challenging, to balance needs versus wants, because health's such a individual notion of what people think they should have from a health system, you know.
Well, now I'm going to confront you with two things that, you know, are just always true with health. First of all, if you're going to talk about health needs, don't think that a hospital is an answer. It usually isn't. Usually the answer...
It's part of the answer, I guess.
It's part of the answer. It's the noisy part of the answer. The silent part of the answer is public health. And we've learnt that because 20,000 people who could have been dead with COVID are no longer dead, are not dead, because of public health things. And all of the arguments about three waters have at their heart public health. So that's one little confrontation. And then the other confrontation is the needs and wants question that you make, is that in health, always there is this sort of squeaky wheel syndrome, or the middle class capture, or whatever the language you want to use, whereby, you know, the person who, like me, who knows how to get attention will get service. And the person who is fearful of breaking and entering someone's doorway, do you know what I mean, of their GP, will turn their bad health in on themselves and be worse off because of it.
Yeah, and I guess I have that experience when I have elder relatives and they're always sort of, oh no, I'm fine really. And they can be like really, really badly not fine. And that's why I always say to people to take someone with you when you're going.
That's right.
So that you've got somebody else to advocate on your behalf. But I'm also quite, I don't know, conflicted about that as well, because I don't think that we should have to have someone there to advocate for us.
That's right.
And it always means that the people who, for some reason or other, whatever that circumstance is, don't have someone there to advocate for them, whether their health is more pressing or their health needs are more pressing or not, they may get less help.
And they do. And
I don't not to blame the medical profession on that either, but I think it's just an example of when you've got people who are really overworked.
This is not an issue of blame.
Yeah,
it's an issue of design.
Yeah.
And you know, nurses and doctors don't set out to discriminate or behave in a certain way. They you know, they generally speaking get out of work, get out of bed to be nice to people and to help them. But you know, institutional racism is not about individuals; it's about systems. It's the way the process is put together. So, and we now know quite a lot about that. So we know that if you've got two people, one, you know, let's go with a classic sort of Maori Pakeha comparison. Both people have got, you know, stomach cancer or something, and if you or breast cancer, because breast cancer is quite well understood, the pathways are quite well understood. If you follow the various pathways, you find, on average, of course there are exceptions, but on average you'll find the Maori person will slip a bit behind in this regard, or that they'll enter this or put their hand up later. They will miss appointments a tad more often. Why? Because they've got chaos in their family that someone else doesn't have. And then you start adding all that up together, and you end up with a different, a different outcome from the disease. And that's a contributing factor to why Māori today die 8.5 years younger than Pākehā. It's a big gap.
It's a big gap. It's a big gap for a society that is sort of, all my growing up years prides itself on, a fair go for everyone and that kind of mentality that a lot of Kiwis think of as inherent in New Zealand and in being a New Zealander. And I guess that for me it's quite, with a science background, the numbers don't lie, whatever people say about statistics. They actually don't lie. And that's when you can tell there's something systemic going on.
That's right.
Is when you've got a clear difference, and that means that it's not individuals, that at each point there's something's happening that's going. It could be just a lot of tiny little things, as you say, like a missed appointment, or someone didn't go to the doctor as soon, or someone didn't get a scan as soon. Someone could afford to have their MRI on private health insurance, so they go,
or they
get a diagnosis sooner, or
they got embarrassed about something. They didn't interact with the clinician because, the clinician was not Māori. And
misunderstandings there as well, because there's a lot of people who don't want to say, if they're in a clinician interview type situation, they don't want to say, I didn't understand that.
That's right.
Can you just say that again? Can you say that a different way?
So I would never hesitate to do that. Many people, Māori or Pākehā, to be fair, or many people do as you suggest. They go, I'll go home and try and work that out.
Yeah, rather than just fessing up.
Yeah, well, make sure you spend your time with your GP to the best of your advantage.
That's exactly right. And your GP wants you to do that too. They don't want to be misunderstood, for goodness sake.
And they don't want to be second guessing.
And I guess it goes all the way down, isn't it? It's GPs, it's nurses, it's the consultant. If you're seeing a consultant or a specialist, it's all the way down. It's making sure that if you have any doubts, and also if you have anything that you're not sure about, that may or may not be a symptom, that may or may not be important, let the GP or the consultant make that decision. Just give them all the information as much as you can. That's what I always say anyway. But anyway, we've strayed from the general health things. So, and a big point that you were bringing up there is that hospitals aren't actually the be-all and end-all of a health needs system.
So the hierarchy for me is absolutely. I know that I've been involved in this hospital for years, so it may be a bit of a surprise to you, but it's no surprise to me. The most important part of the health system is public health. The next most important part of the health system is community health, which has got a various or community and primary. Let's say community and primary health.
So is that GPs we're talking
about?
No,
it's GPs and a whole lot of other things. It's GPs and see your chemist first. It's GPs and ask the nurse across the street. It's GPs and talk to mum. It's GPs and joining a group who've got a similar affliction.
Right.
It's all of that, and that is more effective. I should probably say more cost effective. More cost effective. If I was a Minister of Health again, I know that I get more money by putting it into public health. I know that a vaccination for meningococcal B is just going to deliver. And I know that an extra dose of an extra category of breast cancer drug, Herceptin, for example, will deliver a whole lot less per dollar. I know that.
Right.
The difference is that the woman with breast cancer is probably 45. She's vocal. Her life has been ripped to bits. Her family's life has been ripped to bits, and we know her name and address. And the little 2-year-old whose life was saved by everyone having meningococcal B vaccine and herd immunity happening and all of that, we will never know them.
Yeah.
We never know the 20,000 people who Jacinda Ardern's intervention saved. Excuse the party political broadcast, but we will never know those people. And so in society, it's hard. It's actually near enough impossible to turn down the woman with tears in her eyes and cancer in her breast, who knows that her septin will improve her chances measurably. But in terms of cost effectiveness, if you have a budget, then if you've got to use your budget, then a good health minister and a good health system will always put money towards prevention.
And I guess, and I don't know if you include this in public health or not, but in straying completely from the questions that we've got here pre-arranged, like public health would also include warm, dry, non-fungal houses, because that's if you're going to go for bang for your buck, but actually having a warm, dry house, having enough food, having not having barefoot in the middle of winter, that's all going to be really quite cheap intervention, I would have thought, which would.
Yeah. So now we're getting you've moved one step further into further back upstream into what's called the determinants of health, and good on you because the determinants of health, they're not more important than public health, but let me explain what they are. They are things like full employment. They are things like adequate nutrition, which is what you've mentioned. They are things like tolerance, strangely. That if you've got a lot of tolerance in society, you have way less issues with mental health. Or if you have issues with mental health, you're off to a great start in getting mental health managed or made livable, so tolerance is sitting there as a determinant of health. When I was Minister of Health, when I knew that the unemployment rate was dropping from 3.7 to 3.4%, my heart soared, because I knew that I was going to end up with a healthier population because of the reduction in unemployment.
And I'm just trying to think, that's not totally down to people being employed having more money. I mean, that's got to be part of the contributing factor, but I think there's also a societal mental health thing about actually being employed, belonging and feeling like you're a useful cog in society's wheel.
You haven't been othered by saying we've got no work for you, and you haven't been othered by the government coming along and saying you've got no work. We need you to find some, and putting the onus or the blame, if you will, back onto the unemployed person. So I know that we're getting into serious Labor Party politics here, and we shouldn't. We should talk about a hospital. But that's why I get out of bed to go into politics, and that's why Labor Party people do, I think. Something like that.
I think there's a bit of a lost memory here, because when we were talking before about the impacts of vaccinations, I know full well in my family's history, like when somebody gets sick, I think, oh my God, is it diphtheria? Although we've had a diphtheria vaccine for ages. Like, it's not that long ago since the polio epidemic.
Not so long.
And my grandparents were impacted by the Spanish flu. So, it's interesting that we kind of lose this memory of stuff that happens in our own families that should remind us, or perhaps we don't talk about those stories enough, about why vaccine, why those kind of health programs are really important, because, I could name, who was impacted in our family because there were public health measures that didn't occur. So, So I think that 20,000 about Jacinda is really important.
We put risk into our lives, and I put risk into my life. I came here on my bike, so I came through, as it happens, George Street, Octagon, Princess Street to this studio, and that's risk, So and people will take a risk. They will lean against the health system. They will not put their seatbelt on or whatever it is, and if you try and make people do that, you walk straight into goody two-shoes, wokeism, don't tell me what to do, nanny state, the whole friggin' lot. You're straight into it. So society likes a bit of risk. And so public health professionals are are driven mad by that. You know, look at that person eating white bread,
Oh.
and so on. So,
And I can see that as well, though, because if you spend all day as a specialist, as a cardiologist or something, and then you see people eating a crappy diet and you think, I can just see.
know.
And that's public health money that they can see. And when it's a public health system, I can see. And I'm choosing crappy diet, but it could be crappy exercise or riding around motorbikes without a helmet, or you cycle without a helmet, whatever. It could be, anything that's, is a risk somehow. Climbing a mountain is a risk, just climbing the mountain. Going skiing is a risk. Snowboarding is a risk. And it's one of those trade-offs.
Yes.
I think when we have a public health system, we just say, okay, we're going to treat everyone.
But we will trade off, like I could, if I am very careful, I can be sure of arriving safe and sound at my own death.
Right.
Well, what's the point? You see what I'm saying?
Yeah.
So I have to have adventure or excitement in my life. Most of us do.
Yeah, I guess it brings us to the kind of the relationship between private and public sector things as well, because you could say, okay, well, just if you're going to go skiing, that's risky. You're choosing to do it. You've obviously got the money to go skiing. Get yourself health insurance, and if you have a crash, don't be a burden on the public health system. Go through private health.
Let me disagree. What we've done is we've said to the skier, don't you worry. We've got a nice little system invented for you. We call it ACC. Lean against it as much as you like. There is no fault. There is no blame. You can come here from America and fall off your skis. We'll look after you. It's okay. The benefit of that system, been in place for 50 years now, is that nobody bothers to sue anybody for having an unsafe mountain or an unsafe ski pole or something. And that is really good, because it means that we are able to be a little bit more efficient as a society. But boy, do we lean against it.
We do.
And hence the advertisements which say, have
a hymn.
Have a hymn.
Have a hymn moment, like the guy in the duvet cover at the top of the stairs. Like, I don't know why he's going to walk down the stairs anyway, but yeah, have a hymn before you go do some.
No, I don't know this ad campaign.
Yeah, we'll keep an eye out for it. The rest of us do.
Right. Okay. So we should. Right. Okay. So we shouldn't have private health.
I didn't say that. I was.
I mean, I know I get your point there that the ACC is for that one. But as a second follow up question, should we have private health system?
I think if I was inventing my ideal country from the beginning, I would go public only, pretty much like Britain has. Britain has some private features of it. They've got their terribly expensive specialists and so on. But Britain, unlike New Zealand, has a public GP system, whereas our entire primary health is private sector. And so New Zealand. So your question in New Zealand is idle, because no one's going to change it. The primary health system is always going to be privately owned and demanding support from the state and complaining.
Why does it have to be privately owned? Can we not change it to a public system?
Because you would have to set out to nationalise it, and although you can, and it has happened on the West Coast where actually the GPs are owned by the public sector, because that's the only way they can get GPs to the West Coast. Generally speaking, if you try and nationalise something that isn't failing, then you have to expend a great deal of political capital.
Right.
You only have a certain amount when you're in government. So why would you do all of that for the system's not broken. It's not terrible. It's mostly okay. My GP's a pretty good person, and I just think that it would be the time for that was 1936 or something. What was it? What did you guess?
I think it's about 36. Yeah, when we had to choose between universal superannuation or universal health care.
And the British medical Council came out to New Zealand and bullied the hell out of our politicians and said, don't you try and nationalise the primary health sector, and we didn't. But back in Britain a few years later, exactly the opposite happened, and it was nationalised. Now there's a downside to nationalising. There's a downside to having it in the public sector, but probably it's better, probably.
And dentistry is the other one that is always weird. Like, why is that not part of the public health system? Like everything else,
it's nowhere near part of the public health system.
It's crazy. And like I was reading the other day, and I can't remember where, that it's actually dentistry in New Zealand is actually more expensive than it is in the US.
Oh, that wouldn't surprise me.
And it is chronically. And I think that the flow-on effects of having, teeth problems is huge. As when you go back to talking about that preventative public health thing, and it's clearly part of your total body health. It seems a ridiculous situation to have just teeth.
So let us now announce that we don't have a complete public health system. We don't have dentistry except for children and accidents and a few other exceptions, which are important exceptions. We might have Herceptin for that 45-year-old woman of 15 minutes ago, but we don't have the next cancer drug.
Right.
We have a mental health system which has been a Cinderella for a long time, and we continue to under-invest and under-service an increasing mental health set of issues. So we have a good health system. We've got one of the most cost-effective in the world. We've got one of the safest in the world, and it's nowhere near good enough.
What's the answer?
The best answer is probably progress bit by bit. The next thing that will happen, in my view, will be dentistry. Will be, one political party, I know which one, will come forward with the idea of sort of a community services card for dentistry for poor people, and then dentistry for not so poor people, and so on.
Because you can use your community services card, but you've got to find a provider that will take it, which is part of the challenge.
And it's limited.
Yeah.
So you would improve that service. Yeah.
Mm. And of course, dentistry is at the point where it's so expensive that even people with, full-time jobs often don't do very needed dentistry work.
That's right.
Because of the huge expense in it. Because
That's
everybody,
right.
And people talk about the cost of living crisis and things. I'm not a huge fan of the kind of tagline, the cost of living crisis, because it always costs to live, and it goes up, very seldom goes down, and that's just a thing.
Crisis is an overused word.
Yeah,
Okay.
And I'm sure it's we do have a problem with wages keeping pace with house prices and inflation in New Zealand. That is true.
Sure.
And also our groceries are ridiculously expensive. Oh, my goodness. I was talking to a friend from Australia the other, and she's just absolutely appalled coming into New Zealand supermarkets. And that's that duopoly thing, which I think, honestly, just tax them. Like, they're obviously making masses of profits. Why does the government not just tax them? Is that really that difficult? Sorry, I know you're not in government anymore. And it's not really about hospitals, but I've been dying to ask someone who might know that.
Yeah, but the other question is, you go to Queensland and they're growing cherry tomatoes out in the open, but we continue to grow our cherry tomatoes in glass houses. It increases the cost. We could always say, just import more stuff.
I don't think that's always the answer, though. I think it really is that they're just making huge amounts of profit off the top.
I'm going to stay silent.
Yeah.
Okay. All right.
We better move on.
We'll go back on. So we've got two main questions about the hospital. Is the hospital build actually over budget? And if so, by how much? And what are the real numbers we're looking at here? And how do they compare to other large projects? Now, I understand I've asked a whole series of questions there. But yeah, basically, we're just wondering if you could give us some of there's a lot of numbers being floated around, and some of them are very big.
Yep.
Because in the nature of government spending, numbers are big. But I think it's really useful sometimes to get an expert opinion on big numbers and how they compare with other big things.
Sure.
If that makes sense.
Sure.
Because it's sort of out of our normal everyday scope to talk about billions and millions and things.
It is hard. It is hard to talk about billions because we can't relate it to our everyday lives, and so that's what's going to happen now. But sit back and relax and see how it feels. My first comment is to make the point that at the beginning of a project, uncertainty is great, and at the end of the project, uncertainty is zero. When you've finished, you know the bill.
You know how much it costs. Yep. I mean, that's the way of everything, whether it's a big hospital or just planting a garden.
It is. And so when one looks at things like an indicative business case, from there you'll get numbers which are likely to be much more prone to inflation than by the time you've got to a detailed business case, or by the time you've let the main contract, or by the time the hospital is opened. And so that's one point to make. When people set a budget, therefore, it's at the beginning it's a bit of a finger in the air, and when they set a budget closer to the end, it's much more reliable and much more detailed. The first budgets came out at I think 1.0 to 1.2 billion or something. That might have even been before the indicative business case.
But when you're saying the first budgets, what sort of when are we talking about here? 2017?
Probably about May or June 2017. The July 2017 cabinet paper had the figure at it might have been 1.1 to 1.2. I just can't remember, but of that ilk. By the end of that year, by October 2017, it had already become 1.2 to 1.4. How could that happen? Well, when people did the first budget, they forgot to add the computers. In fact, they didn't forget. They just said, we have not added the computers.
Right.
They've
basically changed the scope even at that stage, because they've said, okay, well, we're budgeting for this building.
That's right.
We're budgeting for all the big things, but, computers are kind of an admin thing as well. And you need them, but you also don't really know how many or how much they cost. The other thing is that when the indicative business case was written, nobody knew where the hospital would be. Right.
So they didn't know what the land would cost, or indeed whether there would be a cost. So what they said was, we will make $10 million out of the land.
Right.
So we will assume that we pay nothing for the land because we don't know where it's going to be. Could be at Whakaari, which would cost us nothing. Though if they'd used that argument, they would have been already into so much detail, it's going to be at Whakaari, that they would have had to start budgeting for the demolition of buildings necessary for the hospital to go up at Whakaari. Yeah. So already we're into. So they said, we don't know where it's going to go, so we don't know what the price of the land is, so it has to be zero.
Right.
We do know that we're going to vacate the clinical services block because it's a dog, and it'll have to be knocked down, and we'll be able to sell the land, and that's $10 million. Right. So that, 10 million's nothing, but it was as if we were going to make money out of. So there was some huge gaps, and by the time we got to the end of 2017, some but not all of those gaps had started to be filled in.
Right.
In particular, the land gap had become an estimate, but the computers still hadn't been added in, and indeed, even today, the figures that we hear today do not include computing.
Right.
So we get ourselves to about 1.4, okay? And at that point, we haven't got computers, and we got ourselves somewhere close to a rough enough figure.
Yeah.
And in fact, I think it might have become at 1.43, I don't quite remember. And then we saw the first of the blowouts, and the blowout was in the order of $200 million. So 1.4 or 1.43 or whatever it was became 1.6 odd. And the cause of the blowouts was the beginning of an inflationary period. So we'd had a zero inflation for 10 years prior. For the first time there'd been zero inflation in a century, and we'd had 10 years of it, even to the point where students were being, I can remember an economist telling me that he had to explain to students what inflation was. So we kind of, some of us had forgotten what it was, it turns out. And then we end up the beginning of the inflationary thing. But the inflationary thing, which is only coming off now globally, not in New Zealand so much, but globally, that was then complicated by a bunch of things, including steel prices in Japan, which went through the roof, the ship, sitting in the bloody Suez Canal for a while.
Yeah, the green one.
It was only a small contribution, but it wasn't. It was more than zero. The advent of COVID and the effect of that on various lines of on various the availability of various componentry, and in general, the cost of living, to use your earlier language, we call it the PPI, the Producer Price Index, for construction materials between Q1, first quarter, 2019, and Q1 this year, 2024, went up by 38%.
I see, that's a lot, isn't it? And it's funny because when you're doing the first estimate, like you can't, like it's a little bit like estimating how long a thesis is going to take to write or how long an experiment is going to take to do if you're an ecologist, because you have actually no idea what inflation is. If you're doing a big project like building a hospital, you really have no idea what inflation is going to do over the period of time that it's going to take to build the hospital. And the only thing you can do, I guess, is to make it as short as possible. Because the shorter it is, the more likely the conditions are going to stay the same.
That's right. So
I would have thought.
So that leads to issues of scope and how you can managing scope really matters. This is now
by scope. We're just meaning just the
what's in and what's out.
What's in and what's out. What we're calling
what's
the project.
in and what's out. I'll give you. Here's a little example. Do you want to be the surgeon who operates in a theatre, which is positively pressurised so that air doesn't flow in when you've got a patient whose body's been opened? Do you want that door to be a door that you kick open or push open, which is normal? Or do you want that door to have a little thing that opens automatically? Like, it's
A
one or the
sensor.
other, you know.
Like a chicken auto door.
Yeah.
Oh.
You know, I mean, it's easy to say, well, let's build a modern hospital, can we have... But that costs.
Right.
And I know I'm giving you that example because we had an argument over it.
Wow.
I can't even remember what the outcome of the argument was.
It's quite a detailed. I mean, it's quite a detailed.
It's me getting right into the weeds to make a point that it is important to maintain cost control throughout a project, and it is really easy to add stuff.
I totally thought you were going to say whether or not you add a parking building to the project or not, or a pathology building.
So the parking building is an obvious example of the government willfully increasing the scope so that they can blow the cost out of the water and frighten us all.
Right.
I'm not moved by it. I know what this bloody hospital was and what it wasn't, and I'm calling those ministers for their deceit. Big strong word, and I'm not backing off it. They are not entitled to mislead the public, and I'll call them at every opportunity. You've just given me one job done. Thank you. But I was making another point, which is that right down in the bowels of the hospital there are opportunities to save money, and they should be taken. I know that I'm sounding like I'm on the wrong side of the table.
But it's that discussion about nice to haves and, gold plated hospitals.
There's nothing remotely gold plated. Hush your mouth. Don't use that language. It is much more That's why I gave the example.
Yeah.
Do we push against the door or does the door open? We both have got both types of doors in our lives.
Yeah.
What are we going to have in the hospital?
Yeah.
And it is down at that level. I'm telling you that we are not building a hospital that has nice to haves or that has architectural flourishes. And nor is it East European. Like, it's a nice building, and it's one to be proud of, and it's one that's going to be functional, but it is not over-spec'd. It is not. And for those ministers to wander into town a few weeks ago and infer that it was, or that it was built in the wrong place, makes my blood boil. So you're getting a bit of that.
Oh, no, I'm totally up for that. Totally up for that. I guess the other thing is that if we're saying that the longer it takes to build it, then the more it's going to blow out, because you're going to have increased costs of just you're borrowing a whole lot of money, inflation's going to change, everything's going to cost more because everything tends to cost more. What is the added cost of adding another review, another consultation round?
About either $4 million a month.
A month?
A month.
How long do these consultations usually take?
I haven't finished your first answer to the first question yet. Or, according to Brad Olson, who's an economist, more like $3 million a month. So the $4 million a month is my calculation, which I did about 4 years ago and got checked against the quantity surveyor, who made a few corrections but said I was basically right. The $3 million is one that is a figure. In fact, he said $10 million a quarter, so that's $3.3 million a month. He said it in the ODT, and I know that he just guessed at it, but he is an economist. So it's of that order.
Right.
And then the answer to your question, how long does it take?
Yeah.
The last time we did this, when we tried to take $200 million out, or we said to the government, if you find 100 million, we'll try and take out 100 million.
Yeah.
We didn't quite get there. We took out 90, and that meant taking out far too much pathology, so we created a problem for ourselves. But that whole process took more than 12 months.
Right.
So take 90, multiply 12 by 4, take it off 90, what do you end up with? Bugger all.
Yeah.
And
like, why are we doing it?
Yeah.
Because we're not actually saving anything, and we're spending money on consultants as opposed to a pathology or whatever, the hospital in general.
And let's be easy on consultants too. Consultants are the architects and the engineers who are sweating to try and make savings.
They're doing what they're being told to do, right? What they're being employed to do.
But you get to destroy hundreds and hundreds and hundreds of drawings. You get to destroy them and start again. So it is very expensive to say that you're going to. I think one of the most useful things I've done with this hospital is demand that the cost of delay form part of the analysis. And I doubt that officials are doing this now. I doubt it because I'm not in the room. I doubt it's just too easy. We'll forget about that. You know.
It's a really easy example though. Everyone who's done a late minute homework type exercise, the longer you delay, the harder it is, the longer you're going to be up late. If you rip it up and start again, it's almost inevitably going to be worse because you've run out of time, and time is money in this case, and you're not going to get, I don't know, I guess you are going to get
Let me give you a problem and a solution which I think is quite important for your listeners to think about. The problem is that we have not been any good at building hospitals. We, New Zealand, have not been any good at building hospitals, and I'll explain what I mean by that and why. The solution is that we've got a thing called the IIU, the Infrastructure and Investment Unit, now part of Te Whatu Ora, and they will mean that we will be able to build hospitals in the future, just like Waka Kotahi can build motorways. Remember, right back to the beginning of your discussion. Why did we not have an ability to build hospitals? Well, we didn't bother. We built in the government that I was part of, Helen Clark government. Annette King was the health minister for most of that time, and then me. We built hospitals from Kaitaia to Invercargill, including some big ones like West Auckland, where there was no hospital at all for 300,000 people, and a new one in Wellington, so on, and quite a big refurb in Auckland. And then nothing happened. There were 2 hospitals built in Christchurch during the next 10 years, 2 only, and they were because of an earthquake. The government stopped doing it, stopped doing it. So all the skills went missing, and we need to now build those skills and have them sitting in the infrastructure and investment unit so that we can continue. If governments want to reduce the amount of hospital build, they can, but they can't eliminate it in effect. And so we've got to be able to continue to build hospitals and roads all the way through. And hospitals have been start-stop far too much.
And presumably that makes it cheaper overall, right? Because you're not starting from scratch each time. Like, there must be some cut and paste in a hospital build, surely.
Absolutely. It means that the 55 square metre surgical theatre that's going to exist in the new Dunedin Hospital will be the same in Whangarei, in Nelson, and Tauranga. It'll be the same. It can have the same bloody colour scheme as far as I'm concerned. I mean, it doesn't need to be different. If it's a bog standard theatre, then it's a bog standard theatre.
Yep. Well, one would have thought. We've only got a couple of minutes left. I was gonna say back to the location of it, because I'm very keen on it being exactly where it is, and I think they made the absolute exact right decision about where they put it. Because in my mind, if the hospital is not a teaching hospital, then that puts a serious dent in the University of Otago, because a lot of people come here for pre-med, and all the ones who don't get into med stay on. Not all of them. A large proportion of them stay on and go into life sciences, anatomy, botany, zoology, marine sciences, all those things. Dentistry, a whole heap of things,
therapy, nursing,
all those things, and that
pharmacy
means that not only is the public hospital one of the main employers in Dunedin, but the university is another big employer, and there is a mass effect to universities and hospitals. Like, a university that's too specialised and too small actually isn't as viable as one that's the size that Otago Hospital is, and it has a huge background. So for me, the only place to put the hospital was right next to the university, pretty much where it was, shifted off to the side a little bit so that you could build one while the other was still standing.
And because an occasional chocolate factory came up for sale.
And an occasional chocolate, well, yeah. So the question, I guess, is there anything else you'd like to add to the amazing pros of having it in that place? And did it really cost a lot? I hear a bit of negative talk about people saying, oh, it costs so much to put it there. But I really wonder how much that cost in the scheme of building a hospital.
Right. Thank you for saying it's in the right place. I think it's in the right place. The Prime Minister of the day thought it was in the right place. She said it needed to be built between the Octagon and the existing building.
Be a disaster.
The university thinks it's in the right place. The city thinks it's in the right place. There are still some people who think it could be in Wakarī. They've neglected the fact that they would need to change Wakarī campus around a bit. It's been downstairs, apart from a few years when it was being replaced at an earlier stage and Wakarī was coexistent. It's been downstairs forever, like over 100 years. So there's no way it's going to be put up in Wakarī. There's no way it's going to go to, Carisbrook or Taieri Plains or whatever else had been mooted. As far as the nature of the site is concerned, it's a pretty dodgy site because it's on reclaimed land. It's low and we have sea level rise coming, and so those were factors that were needing to be thought through. And we had some information on the nature of the land, because we'd done a tiny bit of drilling before we confirmed the site, and we had a little bit of information from the dental school, which had gone up also on that sort of land. So we had some information, but we didn't have perfect information. And we bought the chocolate factory without it being known to be clean, because you can't know that the ground underneath it's clean until you've demolished the bloody thing.
Right, yeah, of course.
And so there was risk there. Now, here are the facts. Piling for both buildings, the little building and the big building, outpatients and inpatients, is complete. The little building's going up, of course, you can all see it. The big building, the last pile went in about, today's Thursday, it must have been 2 weeks and 1 day ago, Wednesday, and was capped. So we now know what the price is. Remember, when the job's done, you know what the price is?
Right, exactly.
The price of the land for Cadbury's was 10.9, or was it 11.1 or something like that, $1 million.
Right.
We got most of a block for a song.
Right. So I mean, that compared to $1 billion or $1 billion+ project, that's like a very small component.
Then we discovered we had some difficulty with piling. Some piles have gone, the average pile depth is 18 metres. Some have gone down way over 40.
Wow.
And some of them are less than 18. We've had contamination and archaeological digs and stuff to sort out. But here's the fact. Leaving aside the land cost, the cost of piling, detoxifying all of the soil, taking down the occasional chocolate factory mentioned, and turning it into rubble, most of which was used to raise the hospital above the flood zone, cost, now that the costs are in, just under 3% of the total budget.
Right.
So if anyone still thinks this thing's in the wrong place, or that we're going to be sunk by hugely expensive piles or something,
they're nuts. They just totally don't understand the process.
Money, the bill's in. We know that. We know how much it cost, and that's it.
Unfortunately, we are out of time now. Goodness me! One last thought. We need to build it. We just need to get on and build it.
Yeah. So how do we get that? How do we progress?
Yeah. So the last thought is that let's have no more egos. Every time we change the health system, every time they change the government, every time we put in a new commissioner, every time some new ego arrives in town or arrives in the country or arrives on the job, they say, well, I'm sure this is outrageous. We need to be able to do it a bit better. I'm sure I can help. And so far they haven't.
Right.
No. Cool.
Thank you very much, Pete Hodgson. You've been listening to the OI Podcast, the shout-out for the arts, sciences and Mataranga Māori.
You can support this podcast by becoming a member of the OI. Check out the Otago Institute for Arts and Sciences on Facebook or our website.
If you'd like to listen again to this episode or others from the series, look for the OI Podcast on OAR FM's website, oar.org.nz.
Brought to you by the Otago Institute for Arts and Sciences, the Otago branch of the Royal Society of New Zealand.
This podcast was produced by OAR FM Dunedin with support from New Zealand On the Air.